Hello, 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 check. Hello, check. Hello, 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 check. Hello, check.
will be presenting 3 cases of screen-detected cancer with 3 different findings and how we try to approach them for the diagnostic workup. Over to Tisha, please.
Thank you so much, sir. Uh, Good evening, everyone. I'm Dr. Twisha, and today we'll be talking about screen-detected breast cancer. We are all aware that screen-detected breast cancer present with unique set of challenges in terms of diagnosis and management. They are often non-palpable lumps. They are very subtle on imaging and have to have a very wide variety of
Recording in progress.
Hello, am I audible?
Yes, you are.
Yeah, and they need very careful radiological and pathological correlation to help us with the treatment decision. So today we'll be discussing 3 such cases. The first case is that of a 68-year-old female. She was asymptomatic and came to us for a regular health checkup. She was menopausal, hypertensive, and had a strong family history of breast cancer. Here is a mammogram from her left breast. If we can appreciate the changes in the mammogram, this is the tomomammogram of the same patient, which makes the changes more evident. So what would you do in such case? We went ahead with an ultrasound of the left breast where we can identify the lesion with peripheral vascularity as shown in the second image. These are the findings of mammogram and ultrasound of the patient. It had irregular speculated mass in the left breast upper inner quadrant, close to 11 o'clock position, measuring 10 into 8 mm, BIRADS 5. And the ultrasound gave irregular hypoechoic lesion with peripheral vascularity in the left breast, which was corresponding to the mammogram, giving BIRADS 4C. So what would you typically do in such a case?
Any comments by the expert?
Dr. Aman, ma'am, if you...
Hi. It's a very typical finding we see on screening mammogram. You can see the speculated mass quite well. You can see it better on tomographic images, but on this case, you can actually see it very well on the 2D image also. The tomographic image just confirms it. And when you do the ultrasound, it's important to correlate it, which they have said, correlate it with the mammogram, because this is a small mass and often you may see multiple small masses. So it's very important to correlate the ultrasound finding with the mammography finding to know that it's the same finding. And this would be a BIRADS 4C case, and ahead you would go ahead and biopsy this.
Exactly.
Dr.
So we
Tusha,
went ahead.
Dr. Tusha, what was the status of the nodes, the axilla?
So they were enlarged but not enhancing.
Can I just add? So on ultrasound, we can't talk about enhancing nodes.
Sorry.
So what we would talk about on ultrasound, more than the measurement of nodes on ultrasound, what is important is the cortical thickening. In Indian population, we often see enlarged nodes, which can go up to 2 centimeters and can be very normal. So it's important, if the radiologist hasn't told you that, to ask them, is there cortical thickening and is there abnormal cortical thickening? So it's not very sensitive, but if there is grossly abnormal cortical thickening, you can say that there's a possibility of a nodal spread. The possibility, not sure. And then if you require, you can biopsy it or not. That depends on what your management is going to be like.
Yeah, absolutely, Dr. Aman. The ultrasound was normal as far as the nodes were concerned. No significant lymphadenopathy on either side.
Dr. Twisha, can I just ask you a question? Because you mentioned that her mother had breast cancer.
Yes,
so what was her age when she was diagnosed, her mother? And was this lady, the lady who you are presenting, did she have any previous mammogram?
No, ma'am. She had just come to us for a first, like a regular health checkup. There were no comparative mammograms that we had to compare it with previous mammogram.
Okay.
Yes,
Okay.
ma'am.
So if there was, is it important? That is what basically we would like to understand. Is it
Yes, ma'am.
important
It
to
is
compare?
important.
Yeah.
If she had a previous mammogram, it would be important to see if certain change, there basically to notice any interval changes, like there could be previous asymmetry or like calcification of sorts or something that she might have from probably a previous fibroad or something old fibroid. Definitely, there will be a difference in the type of findings that we see on a mammogram. But if she has been having a certain finding from a periodic time, then we can still do a follow up. But if there is a sudden interval change in her sequential mammogram, then that is something we will have to pay more attention to.
Yes. So in this particular case, I'm sure Dr. Aman ma'am will agree with me that this is a very, very suspicious and it cannot be left just like that. But in case if there are very tiny, areas of microcalcification which might have been missed previously, and if the present mammogram shows that there is an increase in the area covered by microcalcification, then that is very, very important. Dr. Aman ma'am, would you like to add anything to
So
what we have been discussing?
so when we are talking of especially screening mammograms, and in India, as we do occult screening mammograms, they have to be read in conjunction with old mammography. All the studies that they show with mammography picking up cancers is when they're reading screening mammograms in series, not one mammogram alone. So it's very important to have old mammograms to educate people to keep their old mammograms in, because in India all hospitals don't have PAC systems where we have the old mammograms there. And you're trying to look for subtle findings. You're going to see subtle findings in only when you have the previous mammograms. The easiest way to explain to young surgeons, radiologists, or young residents is when you look at CT scan of a brain, each brain looks very similar. There's atrophy in an older brain or something else. But when you look at mammograms of different people, they're completely different. So there's no normal. The normal you see in a mammogram is the first mammogram of a patient. So that's why the old mammograms are so important to us. A finding like this, I wasn't too worried about old mammograms because it's a very suspicious finding. If this finding with a speculated mass was there even on the old mammogram, I would still call it suspicious. It probably just didn't get called last time because it's very speculated. If the margins were smooth, rounded, and they had an old mammogram, it would change things. But this speculated mass is very suspicious. Whether she had it before or not, you would biopsy it.
And absolutely, Dr. Aman, at Medanta, we have a policy that the previous mammogram, if it has been done in Medanta, we have all the records for the last 16 years. But if they have been done outside, we do ask, but many times patients don't bring them or they have lost it, or many times we are not able to compare. But as a policy, we try to compare with the old mammogram as much as possible. Yeah. So next.
I'm sure for the audience, it is a very important take home from so far what we have discussed is that whoever comes for screening mammogram, whether it is normal or whatever, you have to inform the patient to keep it safe and bring it at the time of next screening mammogram. That is very important. So, Dr. Trisha, please go ahead.
Yeah. So like ma'am said, it was very evident on ultrasound and we went ahead with a true cut biopsy. Now we'll move on, and the finding were invasive ductal carcinoma. We'll go on to the next patient. She was a 44-year-old female patient who was a prospective liver donor, asymptomatic, came to us for clearance for liver donation.
Tusha, just a minute. Actually, we have a very large liver and kidney transplant program. And all patients, they come for certain departmental clearances, including the female patients at breast department. If any patient who is above 40, we are doing a screening mammogram, while the younger patients, we just do clinical examination and clear them. So this is a patient. Go ahead, Tusha.
Yes, sir. So she was a 44-year-old female prospective liver donor, asymptomatic, came to us for clearance. She was perimenopausal and has no family history of breast cancer. So here is her first 2D mammogram. Here we can only appreciate some focal asymmetry in the upper outer quadrant. On a tomo mammogram, there is we can appreciate the architectural distortion.
Dr. Aman, will you like to make a comment?
Raman?
Or anybody?
So sorry, this is only the CC view. You can see the architectural distortion laterally. Do you have the oblique view to see if it's consistent? Or
Yeah, it was consistent.
Yes, ma'am, it was consistent.
Yeah. So if there's an architectural distortion with this kind, you'll go ahead and do an ultrasound and see if you can see anything there. You can do a spot compression view, but with the tomosynthesis, you can see the distortion pretty well. So I would just go ahead and do an ultrasound.
Yes, ma'am. So we went ahead and did an ultrasound, ma'am, but it was not giving any additional significant information as compared to a mammogram in this case. It only showed an oval hypoechoic lesion with cystic changes.
In the area of mammographic abnormality?
Yeah.
Yes, ma'am.
Okay.
There was no
Okay.
more correlation.
Okay.
So this
So,
was a simple cyst you saw in the area, or you saw a lesion which had cystic changes?
Ma'am, the report said there was a lesion with cystic changes, but not clinically correlating with the mammographic.
So it wasn't at the same place. They just saw this incidentally.
Yes, ma'am.
So in this, there are two things. Since she's a kidney donor, you have to clear it. You can't. So the thing is, you can't say I'll follow this because
Yes,
she's a
ma'am.
kidney donor. So you can either do a contrast enhanced mammography or you can do an MRI to rule it out, whichever you have, whatever facility you have in your hospital. You can do a stereotactic biopsy of our architectural distortion, but I would like to see it on the other view before I decide that, because you need to see it's consistent on both views before you need to be sure it's there on the mammogram before you put a needle inside. If you're not sure and it's seen only on one view, probably a better idea to do an MRI or a contrast enhanced mammography and see if the lesion is real or not real.
Right, ma'am. So we went ahead and got a contrast enhanced MRI done for this patient, and we couldn't see the areas of enhancement as marked in the images. There are multiple tiny cystic changes that we can appreciate. So this was the report of the MRI. Focal areas of enhancement with multiple tiny cysts in the left breast upper outer quadrant, close to 2 o'clock position. And there were no other suspicious lesions in either breast. This was given a BIRATS 4.
So what next?
Dr. Shashank, would you like to
Yeah,
comment or yeah?
We would want to discuss with the radiologist, but a BIRATS 4 lesion herein, there are two things. Firstly, would want to do a biopsy, but probably give the clearance at the same time to proceed with the transplant program.
Okay. Dr. Ankita?
With a architectural distortion quite evident, will you like to give a clearance without any tissue diagnosis or anything, and with a non-mass enhancement in a MRI?
So, sir, I would want to do a biopsy, but what I'm trying to say is that won't be an absolute contraindication to the transplant.
No,
I think it is. I think it is.
If it
In
turns out
case,
to be DCIS or LCIA or invasive carcinoma, I think we cannot give a clearance for liver
In which
or
case I would want to
either donor
proceed
or
with,
whether recipient. Yeah.
right.
in which case I would want to go ahead with a stereotactic biopsy, or if MRI guided biopsy facilities available.
Yeah. Dr. Ankita, would you
Can we have a is VAB effective in such cases?
Pardon?
Composite biopsy? VAB.
VAB?
Yeah. Let us see what we have done. And any other opinion?
But we would prefer usually that when we see such cases, see, we are a tertiary care center of malignancy. So usually we see
Yes.
incidentally detected BIRATS 4A lesions with concomitant other malignancies.
Yes.
And we usually have, some surgical intervention which is planned by the other disease management group. We don't usually let the BIRATS 4A lesion derail the plan of treatment. Of course, this is an elective setting or donor setting, so that things would be different. But
Yes.
when the patient is undergoing treatment for another disease, what we try is to do either a sonolocalized excision biopsy during the surgery while the patient is under GA to save
Okay.
sort of time and save the patient a procedure. Understanding the fact that a 4A lesion is definitely not going to probably change the course of the treatment. We do have to obviously discuss this with the radiologist and make sure that the index of suspicion is low, that it is 4A.
Yeah.
And we also have we have data from our center wherein we did most of these cases usually come with a PET scan. It's not that we have done a PET scan, but when we do have a PET scan for the other malignancy and in the same patient incidentally detected 4A lesion, What we can do is actually check the uptake on the PET. And what we've realized that those with an SUV of less than 2 have a very low chance of having any malignancy. So we've started to use that as another predictor of whether or not to really advise another intervention or let the course of treatment go on, and this investigation can go on side by side.
Right. But I'm sure, as Dr. Trupti also mentioned that, and Rajiv sir has also clearly said that, biopsy, especially in this setting, because she is an elective and she is to go for liver donation, probably a biopsy is definitely recommended, and before we give a clearance for, liver donation, isn't it?
So which biopsy the experts will recommend? Whether
Yeah. So,
mammographic stereotactic or MRI guided,
So
or
if you have MR guided vacuum assisted biopsy, you could. If you
we
don't,
have
you
we
could
have
do a
every
tomo.
facility we
You
have
had
every facility with us. We
So
have
it depends
MRI
on what
guided.
you're most confident you're seeing the lesion. If you're seeing it on tomography well, you can do a tomography guided VAB,
So
and you don't need to do an
absolutely,
MRI guided VAB. So it
we
depends
had
on
a
where you're
discussion
seeing your
with our
lesion well.
radiologist and let Tusha tell what we have done.
Right. So for this patient, we have done a tomo guided VAB for the left breast. As you can see, we have also placed a clip in the area of the lesion.
yes.
That is in the right side of the image. So the result of the biopsy was fibrocystic disease with extensive lobular carcinoma in situ present.
Okay. So, Dr. Twisha, what was the indication of putting a clip? Can you tell us, for the
Yes,
sake of
ma'am.
the audience?
Yes,
Yes.
ma'am. So the clip here, it marks the location of the cancer. So after the lesion is excised using VAB, we still know where the lesion was present, and depending on the biopsy, we'll go ahead with the further treatment if the patient needs to, depending on the case, what is the report, if the patient needs to receive any radiotherapy or so we'll know the exact location of where the cancer lesion was.
Not for
And for
radiotherapy, basically
excision,
for
during if we want
excision.
to excise after the neoadjuvant chemotherapy, then also we can do like later on wire guided wide local excision or stereotactic wire guided excision. So if the clip is in situ, we'll know the location of the lesion.
Yeah. So in this particular case, in case if the biopsy comes out as cancer and you need to go for a wide local excision, then that clip can be localized, and that will guide you to perform the wide local excision.
Yes,
Yeah.
ma'am.
Yes. Any other question from the experts, Dr. Ankita, Dr. Shashank, Dr. Trupti, Aman ma'am?
Can I just add one more thing? The clip
Yes.
also adds detail because you've had an MRI finding with a tomo-guided finding. If by chance whatever findings you got were discordant with the mammography findings, when you said it didn't make up, if you repeat the MRI, you know that the lesion seen on the MRI was the lesion biopsied by the marker. In case
Yes.
there's any discordance or something, then your surgical finding, our radiology and pathological finding didn't meet up. You want to make sure that what you saw in the MRI was the same thing biopsied. So the marker or the clip or the marker, whatever you call it, also helps in that.
Correct. I think that's a very important point ma'am has made.
Yes.
Yes.
Yeah, any
Yeah.
chances that we must have missed invasive component because it is florid LCI is extensive? How sure we are that it is extensively sampled?
Dr. Tripti, it was a VAB.
It is
Yeah,
a
yeah.
vacuum.
Yes,
So
I know, but like, have we addressed the entire thing, like whatever was suspicious? I mean, even after VAB, sometimes like when we see, and in lobular, there are such lesions that it cannot be detected on imaging. So there is always this thing, there is very admixed, very subtle kind of invasion. So that is why,
Purpose
Yeah.
of biopsy is to have the representative tissue that
yeah,
we have definitely taken. Whether it has been completely excised or not, or neither was the aim to completely excise.
yes, agreed.
Yeah.
Just because it is lobular with extensive this, I was and radiologically not
Yeah.
very sure.
Yes. And
Dr.
I'm sure it needs further, attention. We
yes.
cannot just leave
Yes.
it just like that.
Agreed.
But today, since we're not discussing the management part, probably we will have to move to the third
Yes,
case.
especially what
I
we have
would
done actually, since her brother has undergone liver transplant, and
Yes,
it
sir.
is a LCIS, there is no immediate hurry to go ahead. So I said,
Okay.
let the transplant patient, your brother, be settled. Maybe after
Okay.
2-3 weeks, we will start
Okay.
working on the management. Yeah.
But
Okay.
Dr. Tushar,
Okay.
just want any comment on comedonecrosis on the histopath report?
Yes, sir.
They have not mentioned about it. They have just said fibrocystic disease with extensive LCIS.
But sir, I mean, if we are moving along those lines of ruling out a disease, then probably the presence of comedonecrosis would have probably changed the plan of maybe planning excision. If it was a extensive LCIS with comedonecrosis, planning the excision at the same time when she's probably donating the organ.
I agree.
Trupti? Yeah.
Yeah, so
Yes.
because just LCIS, like what is the extent, whether it is classical versus pleomorphic, whether it is associated with necrosis and all will matter. Like what is the extent and whether it is high grade or not. I think it needs many pathological features
Right.
to be mentioned.
Correct. Absolutely.
Right now.
So, Tushar, next case.
Yes, sir. So the third case is that of a 64-year-old female who has been screening herself since 2020. She presented to the breast OPD for routine screening. She has strong family history, and her mother died of breast cancer, and she was diagnosed at the age of 75. So here are the reports of her serial mammogram starting from 2020. You will notice that there was an interval change in her mammogram in 2025. This is our mammogram for 2024. In 2025, you will notice microcalcification as marked on the image. So what will you do next in this case?
So this was a very, very small, about 5 to 8 mm calcification, which was not present because all these mammograms have been done at our center. So we could compare those mammograms with the old mammograms, and this was a new finding this time.
So this, if I can answer this, you could do an ultrasound, but I doubt you'll see it on ultrasound. You could just do it to confirm you can't see it, and if you can't see it on ultrasound, you do a stereotactic vacuum-assisted biopsy of the calcifications. You could do an ultrasound. Just sometimes, even with small calcifications, there may be a little mass that you can pick up on ultrasound.
Yeah.
So here is the finding of a mammogram. There was interval changes, small microcalcification at 4 o'clock position, 6 into 5 mm by RATS 4C, and on ultrasound, it was showing small hypoechoic lesion and lobulated lesion. We could not do an MRI for this patient as the patient was sensitive to drugs, the contrast. So like ma'am said, would you follow up this patient or go ahead with the biopsy? We went ahead with a stereotactic VAC for the left breast, and you can see the excised sample on the right side, which has the microcalcification. And the result was high-grade DCIS.
Can we, can I request Dr. Neeta, Dr. Anupma, both of them have joined. Prashashank, anyone to chip in and comment
Yeah.
and
Yeah, just
what
wanted
else?
to make a note out of the 3 cases. Dr. Tushar, you have presented the cases very beautifully. 2 of these cases had a strong family history. So we didn't go into the details of that, but obviously for a lady with strong family history, screening is one part, and maybe we have to customize the screening frequency. But in addition to that, that lady should have been referred to a genetic counselor and have had a family, a pedigree chart made and worked up, counseled for genetic testing as well.
Right, sir.
So, in this particular case, the last one, what is the age of the patient?
At the time of diagnosis, ma'am, she's 64. She has been coming since 58 years of age.
Okay, but ma'am, Dr. Aman, ma'am, I think her mammogram is still looking quite dense, isn't it?
Yes,
You can
surprisingly,
get
surprisingly, her mammogram is quite dense as per her age.
yeah, you do get
Yes,
sometimes you see 60 and 70-year-olds with very dense breasts.
Yeah, yeah,
correct.
yeah,
It's not rare.
yeah,
No, it's not rare,
yeah,
but and since she did not have she could not have MR, you mentioned, right?
yeah.
Yes, ma'am.
Also,
But
can I
since we have a
in this
tomomammogram, so that's why we are
Does
able
not.
to detect these small lesions better
Yeah.
than 2D. Yeah,
I think in this case with this type of calcifications, you don't need an MRI. You would still buy if you have routine. It's a new group of heterogeneous calcifications. You have to
Yes.
biopsy it for DCIS. You don't need to wait for the MRI.
Okay. And after the diagnosis of
So,
DCIS,
Vaishali, if I can
yeah.
just comment.
Yes,
Aman, I
ma'am.
think
Yes.
Vaishali's concern is more about management in terms of how would we react later. So this
Huh.
has come back as high-grade DCIS, and are we happy to excise based on the mammo findings that we have versus, in such a dense breast, would we have anything else that could help us?
Yeah, that is. So
So
after the diagnosis of DCIS, especially in that small area, I mean, I would personally want to go ahead with MRI before management to understand the real extent of the disease.
So I believe this lady was allergic to contrast from what
yeah,
the
yeah.
resident
Yes, ma'am.
presented.
She
Okay.
have
Yeah.
a
Okay.
So Aman, is there anything else we could do?
No, she's allergic to contrast. She's probably MRI contrast. She's definitely allergic to the contrast we use in contrast enhanced mammography. Do a tomography. Do a dedicate. They did mention on the ultrasound two lesions. I don't know if those two hypoechoic rounded lesions were seen on the prior ultrasounds or they're new lesions. If there were new lesions, I would definitely biopsy them also because one was at 2 o'clock and one was at 4 o'clock to just give you is there more disease somewhere else.
Right. Correct.
And we've had serial mammograms with a small group of calcifications. So I think if we don't have MRI, if you had MRI, great, dense
Mhm.
breasts to see the extent of disease. But if you didn't have MRI, localize it, and if you get your margins clear, you're good. And probably just counsel the patient that that would be something.
Yeah, but
Yeah,
I think what you said about the 4 o'clock lesion also makes sense that one would definitely want to biopsy
Yeah,
that.
you definitely biopsy everything you can see before you go in for surgery. So you have a better, I think, since we don't have an MRI to know what extent of diseases, and you can counsel the patient a lot better about what kind of surgery you would do.
Yes. Yes. Yes.
so just
Uh,
one sentence that since we are not discussing management today, but since a question has been raised, we did it widely excised, margins were free, and now the patient is in follow-up for more than 1 year. We have just done a recent follow-up mammogram after 1 year, and everything is okay.
So
okay.
what was the histopath on the excision?
Same DCIS.
Same
DCIS.
DCIS. That and previously it was a VAC which
It
was
was,
done,
it was high-grade DCIS, hormone negative, hormone receptor negative.
HER2 positive.
No, no, not HER2 positive.
So TNB like triple negative.
Triple
Triple
negative.
negative.
Okay.
Probably yes. Yeah.
Okay. So I think if the lesions are managed by one wide local excision, then yes, definitely. But if they are wide apart, one is in one quadrant and the other is in exactly opposite quadrant, then what Dr. Aman ma'am and Dr. Neeta are saying is that we have to biopsy each and every lesion so that that patient can be, offered an optimum surgery rather than, just doing mastectomy or in case if it can be managed well within a single wide local excision, then yes, that makes sense. But otherwise, we need to biopsy. Are there any further questions from the experts for Dr. Twisha?
No, just a comment again coming back to the strong family history. I mean, I understand that breast conservation is absolutely on the charts, but probably the counseling part, if subject to her consenting, if the genetic tests were available, and then that would also have been incorporated into the consultation part
Right.
in terms of
Yes.
what breast surgery to be offered to this lady.
Right.
Correct.
I understand.
Yeah.
I think one more thing is that although yes, all three cases were screen detected, we haven't anywhere mentioned what were the clinical findings. Were any of them palpable at all? I think that's one important thing to mention in
No,
the
ma'am.
history of the examination.
In the very beginning, she said actually these were all non-palpable lesions.
Non-palpable lesions,
No,
ma'am.
okay, all right, all right, all right. Okay.
No clinical findings.
No,
No
ma'am.
clinical findings.
Yeah. So, can anyone from the expert summit or tell us something more about how differently could this have been done, or is that perfectly all right? Neeta, ma'am?
Vaishali,
Yeah, Anupa.
yeah.
Yes.
The last case, actually, I didn't hear the first one, so can't say.
Yeah.
The last case, for such screen detected microcas, we usually just directly do a wire localization and wide excision only
Okay.
because it is financially more viable for the patient. First, to do if you do a tomo guided VAB, that costs
Mhm.
money, then the high grade DCIS, then a wide local excision with a wire lock. So it is
Yeah.
kind of double procedure. So just for the sake of saving the finances of the patient, which is a very common and a very important thing for us, we do
Correct.
only one procedure, which is wire localization and wide local, both for diagnosis as well as therapeutic.
Yes, I think the logistics concern, the financial concerns are definitely important. But whenever we talk about the ideal way of investigating, then surely the way it has been actually investigated is the way to go. But depending on the patient's circumstances and the financial conditions, we can actually modify the way we manage the patients. Dr. Twisha, Dr. Anupma has also mentioned that when we do wide local excision, or especially when you have done a vacuum assisted VAB, what is that particular thing which is very important to understand that the right area has been sampled or taken out or excised? Especially when you are actually sampling or excising microcalcifications.
Post
Uh,
margins.
The specimen
can I answer,
mammogram.
Vishal? So
Specimen, ma'am.
whenever we do any biopsy from microcalcification, we always do specimen mammogram. And that
Yes,
is what we have done to see whether we have taken out representative tissue or not. That's always a rule of thumb that for all microcalcification, we must do a specimen mammogram.
so whether it is the course or the vacuum assisted, specimen
Not
or
only that, if
wide local excision.
As Anupama said, even if we have
Yeah.
to do wire guided excision, we
Yes.
must do a mammogram of that specimen so that it corresponds to the findings on the original mammogram.
Correct.
Okay.
Dr. Prekshi?
Can I
Yes.
just add something?
Yes, Dr.
Yeah,
Dipti.
yeah, yeah. So specimen mammography is one thing, but I also feel that a detailed histopathological report is must. Like whatever lesion we say, we have to quantify, especially in VAB. So when it is usually detected for the mammography detected things and all, like if we are seeing calcification or not, because some
Yes.
calcifications are also different type. Like one we can easily
Correct.
see and one doesn't take up the stain, but on polarizer or maybe on deeper sections we get. So I think as a pathology part also we have to quantify the lesion, give exact high grade, low grade features. Like if it out of multiple things, in how many sections we are giving some exact quantification, mention of calcification wherever possible.
So,
Correct.
Trupti, if
Correct.
I can ask,
Yeah.
how do you quantify tumor size on a VAB?
Yeah. So like for example, like we had this case where you have LCIs. So at least when you have like, for example, multiple fragments of tissue bits or you have 4 5 sections. So at least we can say like if it is an occasional foci or if we see multiple foci across all different sections. So like that kind of subjective like quantification is must. Or you can say out of the total things, what percentage it is. Like sometimes you have
Okay.
like multiple sections, but an occasional foci, like that kind of thing.
Okay.
Because then we have
Okay.
to correlate with the imaging findings if whatever is suspicious, we have taken it out or not.
Okay. Okay. So you may not be able to give us the exact size, but
Yes.
whether
Some.
the imaging
Yes.
abnormality has been
It's
properly
properly
represented in the,
represented.
yeah,
Yeah,
yes.
that is the thing.
Yeah.
So
Yes.
now I think we are, ma'am, are you saying something?
No, no, I'm just asking
Yeah,
you whether we should move on.
yeah, we should move on to the next session. Sunidhi, can you please stop sharing the screen?
Yes. Thank you so much, faculty, for your great input. Thank you.
Thank you, Dr.
Thank you,
Trisha.
Dr. Trisha. Great presentation.
Thank you, ma'am.
Now we'll move to towards the next session, and we'll have another interesting case presentation on Phyllodes tumor, which usually mimics fibroadenoma, but has a very different clinical course as well as management. So for that, we have Dr. Varsha, who is resident at Department of Surgery, PGI Rohtak. I would also like to have the pleasure of introducing our panel of experts. Dr. Nika Nair ma'am is there after spending quite some time at TMH. She is now at Apollo Navi Mumbai. Dr. Aman Daftari ma'am is senior radiologist at PD Hinduja Mumbai. Dr. Tripti Pai ma'am is professor molecular oncopathology at TMH. Dr. Ankita Das Sheth, assistant professor and consultant breast oncoplastic surgery at TMH, and Dr. Shashank Nigam, who is a consultant surgical oncologist and breast disease specialist at Lucknow. So over to you, Dr. Varsha.
And we also have Dr. Anupma, Dr.
Sorry.
Nitesh.
Yeah, we have ma'am with us, and we are also going to get benefit by her presence.
Yeah, so they are
Please,
the
little laugh, ma'am.
mentors.
Yeah.
Dr. Varsha, over to you. Please go ahead.
Good evening, ma'am.
Good evening. Good evening. Go ahead.
I'm Dr. Varsha from Junior Resident 3 from PJMS Rohtak. I'm going to present a case of atypical breast lump. So this is a case of 35 years old female, resident of Rohtak, 12th past, homemaker, and belonging to a lower middle socioeconomic status by modified Kuppuswamy scale. She presented to the OPD with chief complaints of lump in her right breast for 3 years. History of presenting illness. Patient was apparently well 3 years back when she noticed a lump in her right breast while bathing. Initially, it was of 2 into 2 centimeter size, which then gradually progressed to a size of 4 into 4 centimeters over a period of 2.5 years. And then suddenly it increased to a size of 8 into 8 centimeters as gestured by the patient in last 3 months. This lump was not associated with pain in her right breast or nipple discharge, not associated with evening rise fever, night sweats, or chronic cough, and there was no history of trauma as well. There was no history of overlying skin changes over the lump site or over the nipple areola complex. There was no nipple retraction or itchy lesions over nipple areola complex. There was no history of any other swelling in same or opposite breast, in axilla, or in neck region. There was no history of upper limb edema or lesions over upper limb or chest wall. There was no history of suggestive of distant metastasis, such as backache, headache, blurring of vision, abnormal body movements, abdominal distension, yellowish discoloration of skin and eyes, shortness of breath, and blood in sputum. There was no history of excessive bleeding per vaginum as well. Past history. There were no similar episodes in past, and patient is not a known case of any chronic illness. There is no history of any blood transfusion or known drug allergy or no prior surgical intervention history. Personal history. Patient is vegetarian by diet. She was having normal sleep-wake cycle and normal bowel bladder habits, and no history of any substance abuse or oral contraceptive pills intake history. Family history. There was no history of similar complaints in family, and there was no history of any cancer or cancer-related deaths in family. Menstrual and obstetric history. A patient attained her menarche at 13 years of age, and initial cycles were irregular for 2 years, and then she attained regular cycles after that. And the cycles were lasting for 3 to 5 days, occurring at an interval of 28 to 35 days, soaking around 1 to 2 pads per day, and with no excessive dysmenorrhea or excessive passage of clothes. Patient got married at 22 years of age, and her obstetric formula is para 2, live issues 2, and abortion 0. She had her first childbirth at the age of 24 years, and it was a girl child who was by normal vaginal delivery, and the baby was breastfed for 2 years. The second child was at the age of 27 years. It was a male child by normal vaginal delivery and was breastfed for 2 years. And currently her last menstrual period was on 23rd May 2026. Ma'am, should I continue with the examination part?
Yes, please. Or unless the experts want to ask any questions.
Okay, ma'am.
I think at history, maybe you could have a provisional
Yeah, ma'am.
impression of what the diagnosis is.
Yeah, ma'am. My patient, 35 years old female, with she of lump in her right breast for 3 years, which has suddenly increased to a size of 8 into 8 centimeters in past 3 months, is probably a case of benign breast disease.
Sorry, why do you think it's benign breast disease? Because it's increased significantly in size.
Yes, ma'am. Ma'am, first, considering the age of the patient is 35 years old, and second, she is having sudden increase in size, but the swelling which the patient is having is not associated with any other changes like nipple retraction. Though the size of the swelling is very large, but she is not having any other changes like nipple retraction, which usually is seen in case of malignancies.
Yeah, but that will come on your examination. The patient's history alone may not be effective enough to answer
Ma'am,
that.
on probing the patient told about that there was no history of nipple retraction.
So again, patient will not be able to answer that herself.
Yes,
That I think if you are looking at signs of breast cancer, then
yes,
that is something that you would look at after your examination, not during your history. And I think the history of a sudden change from 3 to 8 centimeters is
yes.
something that does not point to a benign lesion. So I'm not convinced that this is a benign lesion for you to be able to say benign. You have to
Okay.
be able to say that this is a lesion that probably needs to be evaluated to rule out a malignancy because of the sudden increase in size. I would be more comfortable saying that I want to rule out some sort of malignant transformation, whether it's inner phylloids, whether it's malignancy, or some sort of cystic degeneration, because there is a sudden increase in size, which is what is concerning in the history. I'm not happy to say this is benign. I mean, everybody else can also opine on that, please.
Surely. Actually, what Dr. Neeta is saying is absolutely right. Dr. Shashank, you want to say anything?
I completely agree with Dr. Nida, ma'am. If you talk about differentials, we would suspect malignancy, and moving forward, first step would be to exclude malignancy, and that kind of history is certainly suspicious. And cancers or malignant transformations, as ma'am said, would be at the top of our list that we need to exclude in here.
Yes. And Dr. Varsha, when you said that since the lesion, I mean, since she had felt this lump 3 years ago, that does not rule out that it cannot be cancer. Because there are, obviously not in this particular case, but there are very slow growing cancers which are there, especially in elderly women who usually come with a history that, oh, I've noticed this lump couple of years ago. So the duration of symptoms alone should not be taken to rule out presence of malignancy here.
Okay.
Okay.
Ji.
Although I must say that you have done a great job of taking a very exhaustive history, but when you talk about clinical history, when you look at each and individual symptom and the progression of the symptoms, at the end of your clinical history taking, before you examine, what Dr. Neeta rightly mentioned was, since it has been there for last 3 years and suddenly it has grown in size, there is no history of trauma, there is no history of any fever or anything which is suggesting that it could be infection or responsible for sudden increase in size, then it has to be taken, it has to be obviously thoroughly examined and investigated. So you could say that I would like to investigate before saying that, oh, this could be benign based on the duration of the symptoms.
Okay.
Okay. Yeah, please go ahead.
So proceeding with the examination part, the patient was examined in a well-lit room after taking informed consent and maintaining the adequate privacy of patient. Patient was conscious, cooperative, and well-oriented to time, place, and person. Her pulse rate was 82 beats per minute in right radial artery, good in volume, regular rhythm, no radioradial or radiofemoral delay. Blood pressure was 128 by 70 millimeters of mercury, taken in right arm, in sitting position at the level of heart. Respiratory rate was 14 breaths per minute. And patient's BMI was 31.2 kg per meter square, which was falling under mild obesity. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema was absent. Systemic examination, the central nervous system examination, higher mental functions were normal, sensory and motor examination was within normal limit. Respiratory system examination showed bilateral equal air entry and no added sounds. In cardiovascular system examination, S1, S2 heard, and there were no additional murmurs heard. In per abdomen examination, the abdomen was non-distended, soft, and non-tender, and there was no organomegaly. Per vaginum and per rectal examination were within normal limits. Local examination was done in sitting position, in lying down position, in semi-recumbent, and in bending forward position, with hands by side, hands above the head, and hands above waist region. Left breast examination was done first, and which was within normal limit. On inspection of right breast, bilateral breasts pendulous in shape, and the right breast was slightly at a lower level and more ptotic than the left breast. There was a fullness noted in outer quadrant of right breast. There were no engorged veins, redness, discharge over the skin of right breast, and there was no ulceration, fungation, purity orange, or dimpling, puckering, or nipple retraction over right breast. On examination of nipple, the right nipple was slightly at a lower location than the left nipple, and there was no discharge from the right nipple. And the surface of nipple was normal. That is, there were no cracks or fissures or ulcer over the right nipple. Bilateral areola were symmetrical with no discharge or lesion or redness over the nipple, areola. There were no nodules on chest or right upper limb, no right upper limb edema, or no fullness in the neck region. On palpation, all inspectory findings were confirmed. There was no local rise of temperature. We noticed a solitary, non-tender, mobile, firm, irregular, lobulated, well-defined 9 into 9 centimeters lump with no fixity to underlying chest wall or muscle and skin in lower outer quadrant of right breast. There was no axillary, supraclavicular, and cervical lymphadenopathy noted. This is the image of the patient that we can see. We can see the fullness in outer quadrant of the right breast in these images. The green part marked is showing the tumor site. Ma'am, this is all about the examination part.
Okay.
Should I summarize?
I think you should now wait for our experts to
Yes.
discuss this case with you further.
So Dr.
I think now
Varsha,
the
again,
first question, sorry. Yeah.
Go ahead, Dr. Ankita, then maybe we can ask Dr. Shashank to
No,
chip
I
in.
think I was asking the same thing. At this point, the first question to any resident is always, what is your provisional diagnosis?
Yes. Dr. Varsha, for you.
Considering the history and examination part in mind, ma'am, my first diagnosis will be more towards the benign pathology in this case. As ma'am said that on the basis of history, we can consider malignancy as our first diagnosis. Then concluding the examination part, I think benign pathology fits more to in this case, as this mass is 9 into 9 centimeter and there is fullness in the outer quadrant of right breast with no nipple changes, and this patient is on examination we got lobulation and irregular surface of the lump, and this lump was mobile. So I think I can consider benign breast disease as my first diagnosis after examination part.
Dr. Shashank?
yeah, and would malignancy be in your list of differentials or not at all?
Yes, sir, malignancy will be in my list of differentials.
Okay, so I mean the points in favor of you calling it a benign disease probably are only two. One, that absence of nipple retraction, which a lot of breast cancers, early breast cancers up till T3 won't have it. And secondly, you are basing your first differential probably because of its lobulated margin. So for younger age women, a lot of times triple negative breast cancers would mimic. So I would still want you to have a word of caution while keeping those differentials with the kind of largest lump, both even if it is a fibroepithelial lesion with the kind of history of rapid progression and the size, I would be more tilted towards calling it maybe a borderline or malignant phylloides, vis-a-vis keeping malignancy in my list of differentials as well.
Okay, sir.
I'm sorry,
Sorry,
I'm
when
going
you say
to.
benign, yeah,
Yeah,
yes, ma'am.
sorry, Ankita, if I may. I don't think you can say benign breast disease at any point of time in this.
Ma'am,
Absolutely
I
correct.
can consider phyllodes in my
So
differential list
phylloids
now.
is not a
Yes,
benign
yes,
breast
benign.
disease, my dear. So when you say benign breast disease, phylloids is not a benign breast disease. Benign phylloids is not a benign breast disease. Cystosarcoma does not come under what we qualify as benign breast disease. So I think you're getting a little swayed with the fact that you know what the diagnosis is and you're using the word benign breast disease. Benign breast disease is something which is fibrocystic disease, which is fibroadenomas, sclerosing adenosis, things like that. Cystosarcoma phylloids is not a benign breast disease. Your differentials at her age with a lobulated margin, with an increase in size which is so rapid, needs to be able to say,
I think Dr.
sorry,
Neeta
Ankita,
has
can you take
unveiled.
this over?
Yeah,
Yes,
Nikita.
yes, ma'am. So, yes, so that's exactly what I was coming to actually. I think when you're saying benign, you're including phyllodes. I know in a lot of textbooks and so you might get confused that they do come under the spectrum of benign, but they're really not benign. Because the first thing is phyllodes itself can be benign, borderline, or malignant. And that is really a very, very histopathological diagnosis. It's not something that you could possibly tell clinically. So we always, especially in such a large lump, if there's nothing else, if you say the word benign breast disease, apart from a phyllodes, what else can really grow to a 9 centimeter lump in a 35-year-old over the span of 3 months? So the first diagnosis will be phyllodes, or if not phyllodes, then even a malignancy, even an invasive ductal carcinoma can sometimes present like that without any skin changes.
Correct.
So you do have to call it malignant. I know the age goes against it, and as residents, we were often told that when a younger age, your first differential should not be malignancy, but that's not the case in the face of such red flags clinically.
Yes. And Dr. Varsha, when you talk about benign breast disease, Dr. Neeta has very clearly told you that then you can talk only about fibroadenoma or, as she mentioned, sclerosing adenosis and all those things, or those fibrocystic, what we call it. But in this particular case, this is a very large tumor with a typical history that it has grown in size. The age is corresponding. A large giant fibroadenoma can be there, but this is not the age where usually the patients present with. They are much younger. But in this particular case, looking at the overall clinical history, the progression of the disease and the clinical findings, this definitely cannot be labeled it as a benign breast lump. Okay?
Okay, ma'am.
Okay.
Ma'am, may I please ask a question?
Yes, please, you can.
Ma'am, keeping the mobility of the lump and nodularity of the lump in mind, can we say that this is this is pointing more towards phyllodes tumor?
So again, Dr. Ankita also mentioned that large triple negative breast cancers also can present like that. You know, uh, especially in younger women, they can have a central necrosis and they can present with large tumors. So only the fact that the tumor is mobile, it is not fixed to the skin, you can rule out cancer. It is not like that. Obviously not like that.
Okay, thank you.
So should she proceed or Dr. Shashank, anything?
I mean,
Would you like to ask any? Yeah.
Yeah, I mean, keeping myself as a resident in her place, I understand where she is kind of fumbling. What we have been always taught in our residencies is truly age is not probably not in favor. The longevity is not in favor, but with the kind of rapid progression and the fact that a lot of breast cancers are actually happening at a younger age, we would need to keep. We can probably start with our differential one as a fibroepithelial lesion with malignant transformation, but a closed differential would always, in such a scenario, be a malignancy. So, I mean, we have to probably, if it is to be told to an examiner, differential one and differential two have to be told in the same go, because with the examination history so far, both the possibilities are very close.
Okay, sir.
So please go ahead. How did you evaluate her?
Okay. After this clinical examination part, we went ahead with the investigation part, that is radiological investigation. We advised ultrasound and mammography to this patient. On ultrasound, we got this finding that a lobulated multicystic lesion with thick internal septations and intracystic solid component seen in outer quadrant of right breast, measuring 9.1 into 8.4 centimeters. Internal echoes are also seen within the cystic component. On color mode, no significant viscolarity noted within the lesion. No evidence of axillary lymphadenopathy noted. And the final impression of ultrasound report was phyllodes, query complex breast cyst on right breast. That is Byrax 4 lesion. Further, we advised mammography, which showed
Go ahead, Dr. Varsha.
On mammography, we got this report, that is breast density ACRA, a radiodense lobulated lesion measuring 9 to 7 centimeters in outer quadrant without calcification and spiculations. So we can see in the image, the upper part is the craniocaudal medial lateral oblique view, and the this part. Upper part is showing the craniocaudal view and lower part is showing the medial lateral oblique view. So we can very well identify the lesion in the outer quadrant of right breast in this image, which is showing lobulation and radiodensity. On further, we advised MRI to this patient, which showed well-defined heterogeneously enhancing solid cystic mass lesion in right breast measuring 9.3 into 8.6 into 7.2 centimeters lesion. The cystic component shows internal fluid level. The solid component shows area of diffusion restriction on ABSI map. Left breast was normal, and there were no enlarged lymph nodes seen. The chest was normal. Visualized lungs and mediastinum appears normal. Bilateral pectoralis muscle were grossly normal, and there was no evidence of skin thickening noted. And there was no nipple retraction seen. Visualized lungs and mediastinum normal. So the final impression of CE-MRI breast was complex right breast cyst favoring phyllodes tumor that
So,
corresponding.
Dr. Varsha,
Yes, ma'am.
can I ask if mammography and sonography was so clear in this patient, why did you do an MRI?
Ma'am, MRI was advised in this patient to see the malignant transformation as diffusion restriction on MRI can tell us about the malignant transformation in phyllodes. So that was advised. Otherwise, usually in phyllodes, MRI is not as such indicate.
This does
Can
not
we?
typically fit into the indication for MRI actually. There are very specific indications for doing an MRI, and this really doesn't fit into that.
Yes, ma'am. The MRI was not actually not indicated in this case, but we just advised to see whether it is showing type C curve or not to see the malignant transformation.
I don't, an MRI would not be very specific to see malignant transformation with such a large mass. You would need a biopsy to figure out if it's malignant or not. I don't think the MRI would add a lot of value. That's all. Then you may see something, but to be specific and say that this is definitely malignant after your ultrasound findings and mammography would be very unlikely. That's all. I know people do an MRI, but it doesn't add much value to it before a biopsy or before a final therapeutic or surgical thing.
Ma'am, can
Okay, I
you?
think it was done in addition to the contrast mammogram. Yeah, that was the contrast mammogram as well, right?
Yes, ma'am.
It was
So,
a regular mammogram. It wasn't a contrast enhanced
It was
mammography.
not.
It was just a very dense
can you go
mass.
back to the mammo page?
Yes, ma'am.
Actually, this is not, this is a
This
regular
was a
mammogram.
plain mammogram, ma'am. The MRI was contrast enhanced.
Okay, all right, okay.
Woman, ma'am, can we, tell our audience as to what are the indications for MRI, especially in the situation where we are clinically suspecting it to be a phylloid tumor?
So, if you're suspecting a phylloid tumor between a mammography and ultrasound, on mammography you just see a mass, most likely circumscribed. Sometimes it's a large mass and you can see lobulations. In a phylloid tumor, you see multiple cystic spaces of unequal sizes on ultrasound. Or you see calcifications and you see a lot of heterogeneity of the mass on ultrasound. That's one of the area. When we see that, we raise the possibility of a phylloid tumor. This tumor increased in size very rapidly, and so clinically also you were thinking of that. But there are many times where you may not think of it clinically as a phylloid tumor, but it comes back as a phylloid tumor, and the imaging findings are pretty classical on ultrasound. MRI doesn't add much to the diagnosis of a phylloid tumor per se. There are no reasons. If I'm seeing there's a palpable mass in a young lady, we are seeing typical findings on an ultrasound, which may be a phylloid tumor. We would go ahead and biopsy it. An MRI is not recommended for it. People do it for different reasons, but it's not one of the recommendations for a breast MRI, according to the ACR guidelines or any guidelines you look worldwide.
Correct. Ma'am, is there any situation where you would suggest MRI in a case of recurrent phylloids?
So recurrent malignant, so when it's malignant phylloids, right now we're not sure it's malignant or not.
No, not in this particular case.
In a recurrent phylloid, sometimes if you don't pick them up on ultrasound, often if it's a recurrent phylloids, you also have a lot of scars because they've already done surgery. So that becomes, when there's scarring, it's always trickier for us on ultrasound and mammography. And then there's a tiny lesion sitting on the scar. You're not sure if there's a recurrence at the scar. So that time MRI helps a lot. And MRI is very good for differentiating scarred lesions, what we see on ultrasound, because we see a lot of shadowing on scars and seeing a recurrence. Recurrence MRI is very good. But at the first place, I don't think it's needed.
Yes.
In this case, I don't think it was needed, done or not, but I don't think it added any value per se. That's my opinion.
Absolutely. Dr. Varsha, I think it is clear for you now.
Yes, ma'am.
So MRI has not added any additional clinical information to what you have already received by doing a clinical examination, ultrasound, and yes, mammography. Is that so?
Yes, ma'am.
Okay. So please go ahead.
Okay, ma'am. So skipping this part.
Yeah.
Then we went ahead with the true cut biopsy, core biopsy from the right breast lump, which showed fibrocollagenous tissue with myxoid stroma with glands and leaf-like pattern, and the findings were suggestive of phylloid tumor.
Can I just add one thing? So in a lesion that is this large, when you're doing the biopsy and so heterogeneous on ultrasound, when you're doing the biopsy, it's very important the needle takes samples from multiple areas, the cystic areas, the solid areas, especially to get a phylloids, because sometimes in a smaller lesion between fibroadenoma and phylloids, it gets very difficult for the pathologist. So in a heterogeneous lesion, when you do the biopsy, it's very important to take samples from different parts of the tumor. That's very important, more than in an MRI or anything else.
Can I make a small comment?
Yes, sir.
Since this is a cystic solid lump, though it is a very big lump, I will ask my radiologist to do the biopsy and the ultrasound so that he can take the appropriate samples from the solid area and cystic area. If I do a clinical biopsy, I may take insufficient sample either from the cystic area or something. So in a phylloid, suspected phylloid, I will definitely like to do an ultrasound guided biopsy, as was told that it should be taken from various areas, both cystic and solid. So that may be, I think the accuracy of the biopsy may increase.
Yes, sir.
Um,
Dr. Trupti, can you, Dr. Trupti, are you
Yes.
there?
Yeah.
So can you please tell our audience about how can you, comment upon whether it is a phylloids tumor or a fibroadenoma, or in case if it is a phylloids tumor, whether it is a benign, borderline, or malignant, especially on true cut biopsy, what are the limitations and the pathological considerations when we diagnose such a case?
Yeah, so it is always a nightmare, and always because these lesions are very heterogeneous, and in biopsy it gets very difficult to capture everything like in such clinical scenario. So it would have been great if you could have put the histopathology images so
yes,
that
ma'am.
I could. You have put?
Yes, ma'am.
Yeah, can you just?
This is the final histopath slides, ma'am, that I got.
Oh, okay. So this is a very high power. So it would have been, so like there are subtle features like when you get different cores. So one at low power at 1x or 2x, when we see lot of small fragmented bits, it is one indirect way to say it is a phyllodes tumor, because it is like a leaf-like structure and a very solid cystic. When you do biopsy, you tend to get very smaller things. Now here, if you see this leaf-like kind of fronds, but at this power we cannot say. So what do we see? We see stromal cellularity, so fibroepithelial, so epithelial component and the fibrous stromal component. So we see how much part of biopsy is occupied by this stroma. So when you see very scanty epithelium, lot of stroma, lot of cellularity, it is like a phyllodes tumor. If you see lot of epithelial component, very less of stroma, then it is like a too much struggle for us. Sometimes in this kind of heterogeneous things, you get lot of areas resembling fibroadenoma. Just having a leaf-like architecture doesn't mean it is phyllodes tumor. We have to focus on the stromal elements. Stromal overgrowth. What do you mean by stromal overgrowth? Where very less of epithelium, and under a lens of microscope, you just see this stroma. Even if it is bland, you see only stroma. Or you see heterologous elements, like you see cartilaginous things, you see very high grade round cells in this stromal cells, or you see necrosis, tumor necrosis. So these are certain findings. Now here, just looking at it, I still cannot call it phyllodes tumor at this power. So when you take histopathology image, you take low power image so that you see how much is the stromal component, or you take high power images to see what kind of cells are there in the stroma, whether there is nuclear atypia, whether there are mitosis. So we see stromal overgrowth, stromal cellularity, stromal nuclear atypia, mitosis, all these things we will have to look at. And it is a very tricky diagnosis. Now, this is a 35-year-old. Sometimes you have this adolescent age group like 12 to 18, less than 20. It is very difficult to say.
Correct.
And you must have seen, like most of the time we give this differential and we say that exact characterization possible on the excision specimen.
Absolutely, absolutely. Because this is what we usually get, that this is a fibroepithelial lesion, and the most probable differential based on whether it is a stromal proliferation or epithelial proliferation, whether it is number one phylloids tumor or fibroadenoma. That is what is the
Yes.
usual way the
Yeah.
core-needle biopsy is reported.
Yes.
Isn't it, Dr.
Yes.
Trupti?
Yes. Yes.
Yeah, right.
Unless we say very high grade features, it is very easy to call malignant. But this heterogeneous, where the differential is between the cellular fibroadenoma and benign phyllodes, it gets very difficult.
Correct, correct. Other experts,
Just would
Dr.
want to
Neeta?
hear Dr.
Yeah.
Tripti on how difficult it is to differentiate a malignant phyllodes with a sarcoma of
Yes,
the
that
breast.
is another thing. So one spectrum is difficulty between fibroadenoma, cellular fibroadenoma and benign phyllodes, and other difficulty is when you just see the stromal component, whether it is a malignant phyllodes versus it is a sarcoma, or whether it is metaplastic carcinoma, sarcomatoid.
Correct,
So always
correct.
in this scenario, when you see just stroma, very cellular stroma, we look at the history of the patient, like whether it was a repeated thing. Initially someone called it phyllodes, benign phyllodes or fibroadenoma. There is a repeated history of lump excision, or you see on imaging finding it is like a well circumscribed solid cystic mass. And then always on biopsy, if these things are there, we end up giving a differential. And we still say on resection also, sometimes we have to take 30-40 sections, and in one section we get the epithelial component. So it is that tricky. So everything in that condition, we take clinical picture, imaging picture, and still on histopathology we have to give the differentials. Some IHCs help, like AE1, A3. If it is diffusely positive, it is a type of a sarcomatoid carcinoma. Or if it be between too much stroma, even if you see some dilated epithelial component, your first differential will be a this sarcoma in a background of malignant phyllodes.
Okay. So, thank you, Dr. Trupti. Is that clear, Dr. Varsha, to you?
Yes, ma'am.
Okay. Anything further, Dr. Shashank, Dr. Ankita, Dr. Neeta? I think Dr. Neeta is not feeling well.
I think at a resident level, I guess one more thing is just that until you're sure it is a sarcoma or a phyllodes or an IDC, and even otherwise, the only one thing to follow is when you're doing a biopsy. Of course, now we don't always chase biopsy scars, but as far as possible to try to keep the biopsy in the center of the lump, which is especially difficult in mobile lumps and ptotic breasts. And the same is when you're getting an ultrasound guided biopsy, to make sure that it is conveyed to the radiologist as well, because it is convenient to put the probe on top and the needle from the side. But
Yeah,
if it is conveyed to them, they can also manage to put the core biopsy in a way that it's within the resection and not an
correct.
eccentric scar.
Correct. I think that's a very important point. From the management point of view, it is very, very important, especially to, have a good cosmesis. I can see some raise of hand, Mr. Manav. Do you want to say something, Mr. Manav?
Hi, Dr. Vishali. I am Dr. Natasha.
Oh, hi, Dr. Nityasha. Please go ahead. Sorry, I could not recognize you from your name.
Actually, this
Please
was
go
the
ahead.
laptop of my resident only.
Yeah.
So, what I want to say that is, R is a government institute. She is
Yes.
my resident only. I told
Yeah.
you. So, ours is a government institute, and our residents are going accompanying the patient to the radiology department.
Okay.
And they are taking by their own this biopsy. They are just showing us putting the probe over the lump, and our residents are taking the biopsy, core biopsy.
Okay.
So we are
Okay.
taking care of that part also, as
Okay.
Dr.
Okay.
said. Yeah.
Okay. So for everyone else, let me introduce Dr. Nitya Shah. She is the head of surgery at PGI Rohtak, and she is the mentor and guide of Dr. Varsha. So that's a great thing, Dr. Nitya Shah, that your residents are performing the biopsies themselves. Of course, with the help of your radiologist. That's a great way of learning how to perform, proper guided biopsies. Anything else from the other experts for Dr. Varsha?
I would just like to make a comment here
Yes,
that
Anupma.
for smaller lumps or vague lumps, we advise ultrasound guided biopsies. I mean, that is
Yes.
the usual trend. And for larger lumps, the residents and everybody does it in the clinics only, in the OPDs. But I have seen the diagnosis being missed even from larger lump core biopsies, because the core biopsy targets the center, which is necrotic, and you get a negative biopsy. So my
Yeah.
recommendation would be to advise ultrasound guided core biopsies even for the larger lumps, as Dr. Rajiv Agarwal also mentioned the same thing.
Yeah. Yeah. So what Dr. Nityasha said was that the residents go to the ultrasound suite, the radiologist guides them, and these residents perform the biopsy. That is what she mentioned.
Yeah, it's
So I'm
routine
sure
in
the
our institute that
okay.
we are for all kinds of lumps, small, big, we are taking ultrasound guided biopsy, and we don't have the facility of mammography guided. Basically, stereotactic we don't have.
Yeah,
So it is
correct.
ultrasound guided only.
Yeah, I think mammographic or stereotactic biopsy is very rarely required,
Yeah.
especially in our kind of scenario where majority of the patients present with symptomatic, breast cancers. So yes, if we are okay with moving on, should we?
Yes,
Dr.
yes.
Ankita, Dr. Shashank, Dr.
Yes,
Nita,
ma'am.
we should.
Yes, ma'am.
Okay. Yeah. Thanks,
Now
Dr.
we'll move.
Varsha. Great presentation. Dr. Prekshi.
Yes, ma'am.
Okay, ma'am.
Thanks, Dr. Varsha. Now we'll move towards the last presentation,
Thank you,
uh,
ma'am.
which will be on pregnancy-associated breast cancer, complex condition and a challenging diagnosis indeed. So pregnancy-associated breast cancer includes the breast cancer which are diagnosed during pregnancy or 1 year postpartum. Usually, the diagnosis is delayed because of the changes in breast associated with pregnancy. And most of these cases are diagnosed in advanced stages. So, I would like to invite our next speaker, Dr. Akanksha Savargaonkar. She is fellow breast surgery at Ruby Hall Clinic. She is associated with Dr. Anupma Mane ma'am. Over to you, Dr. Akanksha.
Good evening, everyone. Myself, Dr. Kanksha. Today, I am going to present two short cases, which is pregnancy-associated breast cancer. First will be early breast cancer case, and the second will be LABC. I would like to share my screen, ma'am.
Yeah, it is visible. Please do it on slideshow mode.
Yeah.
Yeah, perfect.
Is it visible?
Yes.
Yes, it is.
Okay. First case is early breast cancer in pregnancy, a clinical review of ductal carcinoma in situ arising within a fibroadenoma in a 33-year-old gestational patient at 16 weeks of ANC. History of present illness. A 33-year-old female presented at 16 weeks of ANC at our OPD with primary complaints of bilateral breast lumps, which were present since her teenage years. It was painless in nature and stable in size. Her personal history, she did not have any comorbidities. Family history was negative for breast, ovarian, pancreas, colon, and prostate cancer. She was on annual mammography for long-term duration, as there was a benign clinical presentation. Should I move on to physical examination, ma'am?
Yes. Unless there are any questions from. You said annual mammography, but it is
No,
annual
sorry,
ultrasound.
annual sonography. She was
Okay.
on annual sonography.
Okay. Okay. Go ahead. Go ahead, please.
Okay, ma'am. On physical examination, on her left breast, there was lump located at 2 o'clock position, measuring 2:2 centimeter in dimension. It was mobile, firm, and pentless. On her right side, a lump was at 9 o'clock with measures 1:1 centimeter. It was mobile, soft in consistency, and painless in nature. Bilateral lymph nodes was not enlarged or neither suspicious. There was no enlargement at supraclavicular regions also. Should I move on, ma'am?
Even at this particular point, are there any questions for Dr. Akanksha?
Yeah, I'm still stuck to the annual sonogram that this lady was advised earlier. When is what should be the normal practice for a lady who has apparently clinically by all parameters fibroadenoma once examined and tested, would should she be put on an annual sonogram schemes sort of thing?
Yes, sir. We should take the annual sonogram just to check the interval changes. Is there any increase in the size or anything abnormal we are seeing inside the sonography?
I would want to
Akansha,
disagree.
yeah.
Yeah, ma'am.
I just wanted to ask, since how long has she been undergoing ultrasound, and was there any history of biopsy of any of these lesions in the past?
No, ma'am. She was on the follow up since 2020 something.
2020. So last 5, 6 years, I suppose.
Yes, yes. She had those lumps since her teenage years, but she was on follow up since 2020.
Okay. And did any of these ultrasounds mention any increase in the size, and what BIRAD category was mentioned in those ultrasounds?
Ma'am, it was stable lumps. There was no interval changes seen in those, and it was BIRADS 2, 1 or 3. In her previous sonography, there was BIRADS 2 or 3.
2 or 3. Okay. So can we request Aman ma'am to tell us about how do we, follow patients who have BIRADS 3 lesions? Ma'am?
Yeah.
Yes.
Whether they were it makes a difference whether these were ever biopsied or not. If they were biopsied, usually if there are masses like this that we are seeing, which we think are fibroadenomas, and they've been proven fibroadenomas, if they're proven fibroadenomas, then if on a core needle biopsy we've done it, we are sure you've done a good biopsy with a 14 gauge needle, the pathologist is sure it's only a fibroadenoma, we generally follow it for 6 months up to a year. If they've never been biopsied, say if a patient has multiple lesions in both breasts, and you can't go ahead and biopsy four lesions in each breast and just biopsy one, we usually follow them for at least 2 years. So in 6 months, 6 months and a year. Usually in breast, if things are stable for 2 years, the chances of malignancy are less. However, in our country, with so much variation in where the ultrasound is done, with people, a lot of patients and a lot of clinicians, more than in radiologists, a lot of clinicians will send it to us for a yearly ultrasound. But in the West, they're followed for 2 years. Once it's labeled for 2 years, if it's shown stability, we don't usually follow them again. If a patient is getting pregnant, very often we may decide to do an ultrasound before pregnancy, because often in pregnancy lesions increase. So we want to just prove that they're fibroadenomas, and we just want to see the echogenicity of it to make sure that it's not changing during pregnancy if there's an increase.
Correct. So, Dr. Akanksha, one question for you. Since the lumps she presented with were for last couple of years, so why did she come to you? Was there a reference from her gynecologist? Was she referred to you for breast examination by her gynae obstetrician, or she came on her own? Did she notice any change? What was the scenario here?
She was actually living in Poland, ma'am, and she was with Mane, ma'am. She was on a follow up since long years. Then one of the sonography showed BIRADS 4A, which was done at the Poland. So they did a biopsy there also, which was suggestive of DCIS. Then she came back to India as she was pregnant. So she came back to India again, and we have done her investigations again, as there was mismatch in the previous reports and her recent reports.
Okay. So she is, she was staying somewhere else, Poland, you said, and there she was re-evaluated during her pregnancy and biopsied also. Okay. Which side, right side or left side?
Left side. Left side. She
Left
had
side.
BIRADS 4A at the left side.
And it was the same lesion that they call 4A, or there was a different lesion in the breast?
It was the same lesion, 2 o'clock lesion. It was the same lesion. They called
And
a
the
4A
same size?
biopsy. Yeah, ma'am. It was of the same size, 2:2 centimeter.
And did they have the old ultrasounds to compare it? Because that's the most important thing. And if we call something benign or not, a BIRATS 2 or 3, if you're seeing a lesion that's even slightly lobulated or slightly different and we have nothing to compare it, then we would recommend a biopsy at 4A, even if it looks maybe a fibroadenoma. 4A, we might put it as a 4A. So that changes a lot if they had the original images to compare or not.
Ma'am, actually, she was at the Poland, so we don't have the original reports of the sonography. So we did everything again at our center.
Okay.
Okay. Any questions from the experts? Okay. Dr. Akanksha, if she had not gone to Poland and if you had, the ultrasound done here itself and it was reported as BIRAT 3, like the previous, ultrasound reports, would you have done anything further?
I would have, I would like to keep her on close follow-up.
During her pregnancy, right?
Yes.
Okay.
Can I just add, if it was a BIRATS 2 that went to a BIRATS 3, I would be worried. If for 5 years she's been on BIRATS 2 and we've seen no increase, I would ask the radiologist, why have you jumped to a BIRATS 3 now?
Yes. So, what are the indications for evaluating further? That is what I think Dr. Raman ma'am is trying to tell you. That if there is any change in terms of BIRAD category or change in the size or appearance or any additional new lesion, especially in the scenario that the lady is pregnant, all of this is to be taken, further and evaluated to rule out a pregnancy associated breast cancer, isn't it?
Then the question is, Vaishali, is it the same radiologist who has said BIRAT 2 or 3, or it is a different radiologist?
So
Many times there is a difference of opinion in various radiologists. Somebody says BIRAT 2, the same lesion, somebody says BIRAT 3.
That is true. That is true. So, Aman ma'am, how do you guide us? What should we do if there is any change of opinion in terms of BIRAD category?
So if you're following a lesion, if you're following something in 6 months, it's always good to go back to the same place where you did it.
Yes.
The technique is the same, the machines, better ultrasound machines, few measurements, some people, a millimeter plus minus is intervariable, observer variability is there. So what someone else calls 2, someone else may call 3. It's a very subtle difference. It's a question of 2%, a percent here and there. So I think when you're following lesions, it's important to go to the same person, and it's very important for that person. If you go to a new person, they have all the images, not just the reports with measurements. Because you don't want to just see measurement, you want to see what it looks like, how the margins have changed, if the heterogeneity inside has changed. There are a lot of things we see differently, and also often these small lesions, when they're 1 centimeter and all, there may be a second 1 centimeter lesion there which someone may not have seen. So it's very important for the same person to see it, and you have distance from the nip. A lot of other things that we need to put in the report if it's going to be followed by someone else. The depth, because it's for 1 centimeter lesions as a radiologist, it's very easy to miss one and find a new one and think that it's the same one that it was there before, and it's completely different.
Absolutely. My question to Dr. Akanksha will be that in case if she did not have any past such history and she came to you with a breast lump in her second trimester of pregnancy and you find a lump in her breast and it is reported as BIRAT 3 on ultrasound, how do you proceed?
Whether it's a new lesion, ma'am, or it's a previous lesion only?
No. She comes to you now for the first time, there is no past history, no past record of having undergone any breast imaging. You find a lump, you do an ultrasound, and you find a BIRAT 3 report, and she's say 16-week pregnant. How do you proceed? Or is there any other question from the experts, Dr. Shashank, Dr. Ankita?
Well, I would want exactly this question. This is a very
Okay.
good question that we have put up right now.
Yes.
So, I mean, if a lady comes with a new onset lump labeled as BIRATS 3, how would Dr. Akansha want to proceed with that one?
I will assess her clinically, whether there is any signs of malignancy I could see, and then I will like to see her sonography films, and then is there any past history or any family history I would like to rule out, and I would like to keep her in my close follow-up so that whether there is any interval changes or any enlargement on the rapidly enlarging in the size of that lump, because pregnancy can mask the symptoms of benign as well as the malignant cases. So rather than jumping directly to the core biopsy, I would like to observe her first. And if it case keeps on increasing rapidly, then I would like to go to a core biopsy.
Can we ask Dr. Anupma what is her take on this particular? Anupma, are you
So,
there?
yeah.
Yes.
So this lady, the particular problem was that when she came from Poland with a BIRADS 4A report on sonography and a DCIS report on core biopsy from there.
No, Anupma,
Huh.
sorry, I'm asking a very different situation, not
Okay.
particularly this case.
Okay.
A young lady, 2 weeks, to second trimester pregnancy, comes to you for the first time with no past history, but a palpable lump, and ultrasound shows that it is a BIRAD 3 lesion. So, in that situation, would you, considering the fact that she's pregnant, would you, change your approach to that lump differently, or
No,
what?
no, I would keep her under very close follow-up. I would
Okay.
explain to her the importance of not missing the follow-ups and the possibility of SOS doing a core biopsy if I notice any change clinically or in imaging.
So, how frequently would you follow her up in that situation?
So 3 months is general, but I would
Okay.
also explain to her that the lump is likely to increase anyways because of pregnancy-related changes. Even the
Mhm.
benign lumps are likely to increase.
Yes.
So obviously, if she notes any difference, she has to come even earlier than 3 months.
Right. Aman ma'am, do you have any different take on how do we?
If the surgeon or the gynac told me this is a new palpable lump, and unless I could classically, very classically, with every feature, call it a fibroadenoma or a cyst, if I had even a slightest doubt, I would
Mhm.
biopsy it. In today's day and age, I would biopsy it. We miss too much pregnancy unused. A biopsy in a second trimester is a very simple procedure. It doesn't cause any harm to the patient. It
Right.
decreases the stress of everyone around. And
Mhm.
if it's a new palpable lump, I don't think I would wait. Unless it was a very classical simple cyst or a very classical fibroadenoma, which even if it was a classical fibroadenoma, the reason that it's become palpable, I think the chances of me biopsying it is higher, because
Yeah.
any lobulation, anything heterogeneity, there are a lot of features when we call it a fibroadenoma. There are at least 5 to 8 features. If it didn't tick every box, I would be happier biopsying it than following it, because I would not want to miss a pregnancy induced cancer, because
Answer.
we do see them missed very often.
Right. Right. Dr. Ankita, Dr. Neeta, any inputs from your side?
Yeah, I just wanted to ask if, sorry, I got missed that portion, but a mammogram we have established that we can do, right?
We can do a mammogram, but if it wouldn't change so generally in a pregnancy you can do a mammogram. The mammogram radiation to the bellies, but what we generally always start with an ultrasound, If it's suspicious, I biopsy it. And if it's malignant, then we would end up doing a mammogram, because you need to say, if it comes back as a fibroadenoma, I don't need to do the mammogram. So then I wouldn't do the mammogram. So I
But
generally
if
tend to
there was
biopsy the lesion before I do a mammogram in a pregnancy.
okay,
Correct.
but
I
if it's
think
looking clinically suspicious and we feel nodes and ultrasound is also looking suspicious, especially in
No,
second
when you're talking
trimester
about nodes
onwards.
and all, you're talking of a malignancy straight off. That's
Yes,
you
yes, yes.
can always biopsy and then do the mammogram in 3 days. It's not going to change it. Means you'll
I
still
think
get
I
a
agree
complete
with Dr.
picture.
Aman. When in doubt, do a biopsy.
Yes, when in doubt, do a biopsy. And especially, Dr. Aman has rightly pointed out that if there are certain features which are not really ticking the box for a fibroadenoma, especially in the situation where there is a pregnancy associated clinical situation, then I would also rather do a biopsy, because ultrasound guided biopsy does not put the lady in or the baby in any harm. So it will in fact give us a peace of mind, and we can surely give her a great confidence that it is not malignancy which we are dealing with here.
In fact, memo
Dr. Akanksha,
memo
yeah,
is not going to contribute anything in this case. 16-week pregnancy, the breasts are slightly edematous, young patient. I don't think memo is going to contribute much.
And if I can
and
add
yeah,
something more, I mean,
yes,
following, if we were to put this lady on surveillance, the radiologists are only going to find it much difficult each time because of the other pregnancy-related breast changes that would set in. So, I mean, I would want to hear it from
correct.
Dr. Aman, how tough it would be with the increasing age of pregnancy, localizing this lesion.
Increase with ultrasound, we'd still see it well. We see other changes in the breast. You see a lot of vascularity, you see a lot of ducts, you see hyperechogenicity because of the breast changes in pregnancy. We'd still be able to see the lesion well, but just following a lesion, I think especially because it's a palpable lesion, just puts a lot of anxiety on the patient as well as the doctors around. And
Correct.
it's a very safe procedure doing an ultrasound guided corneal biopsy. If it was
Correct.
not a safe procedure, then it's very safe. It takes hardly 10-15 minutes. There's no side effects per se. You're doing it early enough, nothing happens. So I would rather do a biopsy. And as Dr. Agarwal said, the mammogram does not add anything. That's why we don't do the mammogram before we do a biopsy. If the biopsy comes back as malignant, it's a different question. Then you would definitely do then you need the whole workup. Then you're talking for malignancy. The chances of
Yes,
this coming back as a fibroadenoma is high, but we want to prove that it's a fibroadenoma, so we don't need to look at it during the rest of the pregnancy, per se.
correct. Yes, ma'am. Thank you. I think Dr. Akanksha should proceed, because we have still one more case. So, Akanksha, please go ahead.
Okay, ma'am. During her diagnostic ultrasound, this was from her Poland, targeted USG finding was left breast 2 o'clock upper outer quadrant region with suspicious features, which was categorized as Barrett's 4A. And then they did a USG guided core biopsy, which was done also at Poland, which was suggestive of this was her final true cut biopsy report from outside. It was suggestive of presence of ductal carcinoma without clear features of stromal invasion. Cytologically, the cells are well differentiated, low grade. In 2 ducts, they have seen a focal necrosis and proliferative changes with morphology of atypical ductal hyperplasia present. Her IHC was P63 positive, CK14 positive, ER positive, PR positive, and HER2 negative. Final diagnosis was ductal carcinoma in situ, solid type of mammary gland.
Dr. Trupti,
Yes.
how often do you come across, such a, pathological situation when there is presence of DCIS in a fibroadenoma, and how?
Very rare, like we do see like colonization of, so we see a typical fibroadenoma, and then we see it is colonized with florid sclerosing adenosis, and in sclerosing adenosis there is DCIS, or there is florid LCIS, which is colonizing fibroadenoma. So though rarely, but we do see. But here in the histopathology, there is no mention of fibroadenoma only.
Yeah,
So
there is no mention. I think clinically and radiologically it looked like a fibroadenoma. However, the core needle biopsy mentioned only DCIS. Dr. Akanksha, Is that correct?
Yes, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
Okay. So it was not in the background of fibroadenoma.
Fibroadenoma. So it is just a DCIS.
Okay.
But then, like, you saw a very well-formed mass like a FA,
Yes,
right?
yes.
Yeah. So maybe because DCIS was seen, they didn't, I don't know, like pictures would have been more.
Akanksha, go ahead. Akanksha,
Yes.
go ahead. The further will guide it.
Clarify. Okay.
Okay,
Yeah,
ma'am.
okay.
Go ahead,
Okay.
Akanksha.
Then we did a repeat USG at our center, which was suggestive of bilateral fibroadenomas associated with small adenotic nodules. And then we again also did a core biopsy, as there was no biopsy blocks available from her previous biopsy. So we did it again at our center, which was, this is the core biopsy slide, and which was suggestive of benign proliferative breast lesions with marked usual hyperplasia. No definitive evidence of DCIS or IDC is identified. ER shows heterogeneous expression. At our center, we did not see any DCIS, ma'am, or any typical hyperplasia also seen. So,
Okay.
because there was, should I move on, ma'am?
Yeah, go ahead.
Yeah.
Then we did, as there was no mismatch between two histopathological reports, we did a left wide local excision during her second trimester. Post-operative monitoring confirmed a safe recovery with stable fetal cardiac activity and progress. Then after the wide local excision, her final histopath suggestive of ductal carcinoma in situ, grade 2, arising entirely within a pre-existing left breast fibroadenoma. Growth pattern shows classic solid at cribriform patterns and associated comedonecrosis. Receptor profiling was proved to be strongly positive for estrogen receptors, and her surgical margins were clear. All margins were clear. It was confirmed successful complete local excision. These are two slides which showed the. I'll get back to my slide now. This is the DCIS component we can see here, and this is the fibroadenoma component we can see here.
Actually, this looks like lot of, this is, I don't think, so there is one fibroadenoma, and then on the other side, it is like a florid sclerosing adenosis. And in that, there are few foci of this epithelial hyperplasia. So it is, this entire thing is not DCIS. This is what I can make out from this picture. Am I audible? I don't think I will be
Yes,
able
yes.
to.
Yes,
So
yes.
the DCIS जो बोला है ना, उसमें वो काफी, this is all like a sclerosing adenosis, and in that there are few foci which be like, this is a very low power for me to see. So this is what I was saying, कि sometimes you get like a FA, and then you get sclerosing adenosis, and then inside you get some like ADH or DCIS.
Okay.
Yeah, so it would be very interesting to see ER in this case. So,
Strong
like,
positive.
what it is?
It is strongly positive for ER positive.
Okay.
Okay.
So, sometimes the intensity is strong, but we have to see whether it is heterogeneous or whether it is diffusely seen. So
Okay.
just the absence of CK56 in some cases is not sufficient. In papillary lesions, yes, CK56 is very helpful. But in certain other lesions, no, it is like, for example, you have columnar cell alteration, atypical columnar cell alteration. CK56 is often negative. So
Okay.
ER will be very helpful in these cases. And also in pregnancy related, now there is lot of lactational changes which make the cells look very atypical. So that also we
Okay.
have to be aware of. Yeah.
Okay. So in this situation, probably, I'm sure Dr. Anupma has done a great, care of this, because the margins and everything are clear. But is it suggested that, Dr. Tripti, that we should get a pathology reviewed elsewhere also?
Yeah, or maybe like just if you have a scanned images, just we can see, because this is a
Okay.
very low power for me to comment on anything, but
Okay.
definitely I think there is a
It
foci of
was
sclerosing
reviewed.
adenosis. And sorry?
It was reviewed.
It was reviewed in 2 different centers apart from ours. So 3 times this has
Okay.
been reviewed. Yeah.
Okay. Okay.
And none of them called like it is sclerosing adenosis also, which is colonized by?
No, DCIS was confirmed.
No,
Because,
DCIS, no, DCIS must be there, but I am
Yeah.
saying like as I was saying, like no quantification, like not everything which is looking cellular looks DCIS to me here. It is definitely there is this sclerosing adenosis, and most of the time it comes hand in hand with this fibroadenoma and all this. And then there are some foci which has DCIS or LCIS.
Okay, so from a surgical point of view, we don't really focus much on sclerosing adenosis, so I really don't remember whether the report had that. But DCIS was definitely there, that I remember very well. We reconfirmed and rechecked it because she was pregnant and we had to plan her further treatment. So that was for sure. But as you are saying, yes, sclerosing adenosis, it would be important to know that.
So I'm sure this is a very interesting and a great, way the patient was managed, Dr. Anupma. I think we should move to the next case, Dr. Akanksha,
Yes, ma'am. Yes, ma'am.
because we have only 15 minutes now left.
Yes, ma'am. The second case is pregnancy. Second case was LABC, a 39-year-old second gravida in her second trimester presenting with rapidly growing right breast mass. She has no known comorbidities. Her present history of present illness was she was 39-year-old, G2P1L1. Gestation at the time of presentation was 24 weeks. Her chief complaints was painless right breast lump, which was growing over the time of 2 months. Lump was first noticed at the 7th week of gestational. She ignored it as she was breastfeeding her first child. It then evolved to a painful, rapidly enlarging mass. She then consulted a gynecologist, which advised FNSE, which showed a malignant cells. Then she was referred to a breast surgeon. Her family history was her maternal grandmother has carcinoma, but the details was unknown. On clinical examination, her menstrual and obstetric history was age menarche was 13 years. Her first pregnancy was as 37 years, which was a late maternal age. The mode of delivery was C-section. Now the first child is 2 years old. It was adequately breastfed and weaned shortly before this pregnancy. Her current pregnancy, she's second gravida, conceived at the age of 39 years. I would like to move on to a clinical presentation. Should I continue, ma'am?
Please go ahead. Please go ahead.
Yes, ma'am. On inspection, there was generalized puree orange across the entire right breast surface. On palpation, there was 12 to 10 centimeter hard irregular mass, which was mildly tender, which involving the all 4 quadrants. The T stage was T4B. Fixity, the lump was fixed to overlying skin, mobile relative to underlying pectoralis major muscles. Right axillary status was 4:3 centimeter fixed mass. It was non-tender and there was no supraclavicular nodes palpable. Systemically, there was nothing significant. Then we did a primary investigation as she was pregnant.
Akanksha, just a moment. Let us ask our experts whether they want to intervene here and before you move ahead. Dr. Shashank, Dr. Ankita, with the clinical history and presentation, do you have any questions for Dr. Akanksha?
I think in this case, it's quite clear that we're dealing with an LABC. So we have to ask very specific and leading questions for sites of malignancy. Because, of course, the metastatic workup that we can do in this patient is going to be very limited. So we have to be very, the threshold has to be very low for us to pick up any symptoms for symptom-directed metastatic workup.
Yeah, Dr. Akanksha, I have one question. Considering the fact that the lump really was very big, it progressed rapidly. She is in a second trimester. Her age at conception is 39 years. All of that definitely pointing towards malignancy, history, clinical examination. Is there any other differential you would like to consider here?
as she was breastfeeding, there might be a galactosele or a breast abscess, or it can be a lactating adenoma. But after seeing her clinically, there was clinical signs of malignancy like enlargement of lymph nodes and today orange appearance. So it was clear cut a malignancy.
Yeah, so clearly the first clinical assessment would be of breast cancer. However, rarely, very rarely in this situation, mastitis also, because she has been lactating and all that, but definitely we have to rule out that it is cancer. Go ahead, go ahead.
Then we did a primary investigation ultrasound, which showed a hypoechoic solid mass, subcutaneous edema consistent with pure orange appearance, multiple enlarged nodes with maintained fatty hilum. The left breast and axilla was unremarkable. Then we did a core biopsy, which showed IDC grade 3. Her IHC status was triple positive. She was ER positive, PR positive, and HER2 positive. Ki67 index was 75%. Her initial clinical staging was CT4B, N2A, M0. It was a stage 3B.
Dr. Akanksha, I can see that the clinical size which you mentioned was nearly 12 centimeters. Did you or did I? Oh, okay,
Yes.
okay. No, clinical finding, clinical.
Yes, ma'am. I'll go back to clinical findings.
Yeah.
Yeah, it was
12 into 10 centimeter. And the ultrasound shows it to be a 5 centimeter.
Yeah, ma'am, because she first went to a gynecologist, which suggested her FNSE. Until the time she came to us, it was progressed to this. Clinically, it was 12 to 10 centimeter. The ultrasound was done 1 month before.
Oh, okay. So before coming to you, the ultrasound was done.
Yeah.
Okay.
So, Dr. Akansha, do we have a recent ultrasound report as well? I mean, did you do a repeat ultrasound once she came to you with that kind of progression?
No, sir. We did not repeat ultrasound. We directly proceed to core biopsy.
No, but because my question is with regards to the axillary findings, finding a 4 by 3 centimeter fixed nodal mass, which turns out on ultrasound as reactive with fatty hilum. I mean, we need to discuss with our radiologist once again, probably. Can you move on to the USG findings once again? The next slide, please.
Yes.
Yeah, so multiple enlarged nodes, but with maintained fatty hyla.
That's clearly a very non-concordant, ultrasound result. But probably this was done, Dr. Shashank, this was done before the patient came to them.
Yeah, I agree, ma'am. Just to highlight it to Dr. Akansh and other trainees that if the imaging shows a palpable node which is on imaging looks like a reactive node, we should probably the final clinical stage we will have to incorporate the radiological findings and thereby probably keep it as N0. If we were to rely on this report as the final report, then the clinical staging would be N0.
But obviously,
I don't think in a multiple enlarged nodes, even if they have a fatty hilum, I'll put it a clinical stage as N0. Clinically enlarged nodes is N1.
I think probably the ultrasound, what you really need to know on the nodes is the cortical thickening, more than if the fatty hilum is, if their nodes are enlarged, if the cortical thickening, which if there are multiple enlarged nodes, they can have a fatty hilum, but the cortical thickening is probably increased, which has not been mentioned in this report. So
yes,
you probably
absolutely.
need to repeat the ultrasound to say, I mean, the way the picture is, it looks like the nodes are enlarged. If you are feeling them, we are probably going to see cortical thickening.
And any tumor which is more than 5 centimeter with a PUD orange and clinically 10 centimeter and large nodes, I cannot ignore those nodes.
Right. Dr. Aman, here, is there any role of mammogram? Although on the side of the symptom, the lesion is pretty large and, you know,
we would
yeah.
still do a mammogram. One, you want to see if there are any, it's an IDC, you want to see any calcifications that are extending beyond the mass, just to have an
Yeah.
idea. And also the opposite breast.
Opposite
You
breast,
want to be
yes.
very important to just make sure there's nothing happening in the opposite breast, because you're probably going to treat it with neoadjuvant chemotherapy. So you want to make sure there's nothing going on there.
Correct.
So I would do a mammogram. As in a case like this, we would do a mammogram and ultrasound. We would have probably repeated the ultrasound.
Yeah, and with proper shielding of the baby.
Shielding of the
shielding abdomen.
Shielding of the abdomen, and talking to the before in shielding, just talking to the patient, talking to her about the radiation and telling her about the low risk and everything else.
How old the pregnancy was?
Dr. Akanksha?
7 weeks.
24 weeks. 24 weeks. 24 weeks.
24 weeks. Yeah.
Dr. Ankita, do you have any question at this stage for Dr. Akanksha?
That when we said that she said it was a nodal mass, a 4 centimeter nodal mass, which was fixed.
Yes. Yeah. You're not audible actually.
Am I audible now?
Yes, you are.
Yes. So I'm saying
No, we lost you again.
I'm sorry, can you hear me now? Hello?
Hello?
Yes, can you hear me now?
Not really clearly, but please go ahead, ask question.
Thing is, having a clinically fixed nodal mass is a very
Yes.
clear N2 disease. So we could very safely say that. And
Yeah.
yes, like Dr. Aman ma'am also said, a mammogram would be necessary with an abdominal
Yes.
shield, and it's absolutely safe and essential in picking up CALs. I just wanted to also say that maybe it would have also helped us in the previous case. We do mammograms for our pregnant patients with abdominal shield. Of course, only if there is any suspicious finding to look for calcifications for DCIS. So, I would agree with ma'am here that a mammogram over here is absolutely safe and probably essential.
Yes. Now that we've got a diagnosis and we know that it is a locally advanced breast cancer in a 24-week pregnant lady. So what is the next, investigation which one needs to do here, Dr. Akanksha?
Ma'am, we would like to proceed a core biopsy here and the systemic evaluation to look for myths.
Core biopsy you have already performed. You have told us that it is a invasive ductal carcinoma. Yes. Now the workup bit, the systemic workup. Is it necessary and how would you do it?
Yes, ma'am. She is a stage 3.
Yeah.
So I would like to do a systemic workup, and she has also axillary nodal mass. So systemic workup in late higher stage of breast carcinoma, we would have to do a systemic workup.
So, Aman ma'am?
Yeah, so you could do it.
Yeah.
Go ahead.
No, you please. I wanted your, opinion on this.
And ultrasound. So you cannot use any contrast. So you cannot do an MRI with contrast, or you cannot do a PET CT or CT with contrast. So you do an ultrasound abdomen, or you do a chest X-ray. You can do a non-contrast MRI, but it wouldn't find much stuff for you. So you probably just go with this at least till the end of pregnancy.
I'm sure she has mentioned everything, and we have come to a logical conclusion that it is a, locally advanced case. Obviously, we are not going to discuss the management here, but if there are any further questions which our, audience would want to know, or if the experts also would like the audience to know, please
Just
go
one
ahead
thing I'd
and
like
ask.
to add here that chest X-ray and ultrasound abdomen, of course, are the modalities for metastatic workup that we would use, but we have to also be very careful that we're checking the LFTs for any raised
Yes.
alkaline phosphatase and asking for any specific bony sites which are painful, persistent focal bony pain. So
Yeah.
in that case, it is an indication to do an MR of the spine since we can't do anything else at this point.
Dr. Shashank, do you agree with what Dr. Ankita said?
Yeah, exactly. Following up alkaline phosphatase and carefully evaluating for any systematic symptoms would be essential. And just
Yes.
wanted to make a general comment on the fate of pregnancy-associated breast cancers. This last case is a classical presentation wherein this lady, probably with a greater awareness, could have had been diagnosed at a much earlier stage. But
Yes.
I mean, that is how a lot of pregnancy-associated breast cancers go on unnoticed until they have gone to this kind of picture, wherein the prognosis is obviously bleak.
Absolutely, absolutely. So the whole objective of putting these two cases, Dr. Anupma mentioned in the beginning itself, was that we have to not miss cancers in pregnancy because there are so many, fallacies in clinical examination, especially in a lady who is pregnant with engorged breast and all. We are more likely to miss, any suspicious finding in pregnancy. So that is very important that the patient who presents with any breast related symptom, rather she may not be presenting with any breast related problems, but it is important for all of us to examine the breasts of a pregnant lady at regular intervals throughout the pregnancy and educate the pregnant women to do breast self examination and report any breast related changes if they happen to notice to their gynecologist or to the breast specialist nearby. So this is very important for us to diagnose pregnancy associated breast cancers at early stage. If there are no further questions, then Dr. Rajiv sir, Dr. Goel, Dr. Prekshi, anything else which we have probably not discussed, because we have already overshot by 4 minutes.
Any comments by Anupama for the last case? She is the mentor of the fellow.
Yeah, so basically the same thing, only diagnostic difficulty is a lot more in pregnancy associated breast cancers. And in the first case, of course, I think the take home message is that even if there are multiple bilateral fibroadenomas, be very, very careful, especially during especially during pregnancy. And in the second case, even such a large lump many a times gets missed or misdiagnosed because it is not suspected. We still have a lot of doctors, who tell them ki ye doodh ki gaant hai types. So patients still come to us with that ki humne check karaya but doodh ki gaant hai karke bola during pregnancy.
Correct.
So
That's a very common
very
way
common scenario.
Yeah.
So we really have to keep our antennae up basically and be extremely sure that we have ruled out malignancy during pregnancy.
Agreed.
Yeah. Shashank, Dr. Ankita, any
Yes, ma'am.
comment?
I mean, for pregnancy-associated breast cancer, the lady is already under follow-up. I mean, those are kind of missed opportunities. And as you have rightly pointed out yourself, that I mean, probably it is already there, but it is not being practiced. Every gynecologist for every OBS visit, for every ANC visit, needs to have a mandatory breast examination. And जो मैम ने बोला अनुपमा मैम ने कि वो दूध की गांठ है, majority of those are not even examined. The patient brings it to the notice of the physician. The physician would outrightly, because it is associated with pregnancy, would exclude it and not even bother to examine. And the lacuna is the bridge that we need to fill up is huge in this scenario.
The problem is that we have to sensitize the gynecologist about breast problems. Before saying any breast lump that there is nothing to worry, it is either doodh ki gaant or it is benign. I think the most important thing is to sensitize the gynecologist that this breast lump should be evaluated by the proper person, because
Yes.
they are unfortunately missing a lot of cancers in the early stage.
Yeah. Dr. Prekshi?
In my center, the moment patient says breast, the gynecologist says nothing to do with us, you go there.
Right. Yes. Anything or else we wrap up today's session? Dr. Prekshi?
Yes, ma'am. So great
Should I?
presentations by all the presenters. And now I would request you to give vote of thanks.
Yeah, that's a great job. I really enjoy doing that. So at the outset, I would like to thank all our young presenters and their mentors. So thanks to Dr. Twisha, Dr. Varsha, and Dr. Akanksha for such wonderful and painstaking efforts at collecting the history, the images, and the pathology. Thank you so much. You have been great. And Dr. Anupma, Dr. Nityasha, Rajiv sir, of course, for guiding them and mentoring them. All thanks go to my expert colleagues, Dr. Shashank, Dr. Ankita, Dr. Neeta. She was unwell, but she joined. Thank you so much, Dr. Neeta. Aman ma'am, Dr. Tripti, everybody, thank you so much. I thank my team, Dr. Rajiv sir, Dr. Goel sir, Dr. Prekshi, Dr. Safalta, and last but not the least, I thank all my audience to be consistently with us in all the webinars and encouraging and motivating us to carry on with these efforts. And the entire team of Mighty Duo, especially Sunidhi, who has been always there in helping us, manage these webinars without any technical flaw, without any technical glitch. So thank you so much. And I'm sure we will come up with our next webinar very soon. We'll announce the topic, and we would rather seek your consistent support and presence in these webinars. So have a wonderful night and have a great day. Thank you so much. Thanks for being with us consistently all the time. Thank you, Dr. Trupti. Sorry, I forgot to shut you. Sorry. Sure. Thank you so much and have a great night.
Same to you.